Thank you very much, Eric, and I think that has served as a great introduction on how malaria has to be seen in the broader development context and the changes that are indeed taking place. What we will now do over the next few minutes, first talk a little bit about where we are with the global technical strategy for malaria. And one of the two documents, the one that, as Eric mentioned, says or aims to say the what, the where, and the when, followed by the sister document, the GMAP2, that really deals on the how. So, why do we need a new global technical strategy? Well, for a good number of reasons. First of all, the last decade, in fact, more than a decade, have actually witnessed the unprecedented progress in malaria, both in terms of disease reduction and progress towards elimination in some parts of the world. This has been a consequence of the massive increases in resources that have been made available with the tremendous scale-up of in the deployment of tools. This year, and Richard will correct me otherwise, more than 200 million nets will have actually been delivered in Africa. So, is this time for content? No. In the face of this massive scale-up, there is still a very long way until elimination of malaria has been achieved, and in the meantime we have to manage not only with access but also the challenges of parasite and insecticide resistance. So we believe, or the World Health Assembly believes, is needed to address the heterogeneity and changing dynamics of malaria in order to secure continued progress. And that's why the new global technical strategy is being developed to cover the period 2016 and 2030. A few words on the process, because indeed a lot of the product is the process itself, and we often talk of country ownership and empowerment, but often documents and strategies are developed in a very much top to bottom approach, and we've been trying to shy away from that. Indeed, in May 2013, World Health Assembly called for a new global technical strategy to be developed. A steering committee was set up by WHO, and that steering committee worked with the global malaria team at WHO in developing the first drafts. Very early on, those early drafts were shared with the Malaria Policy Advisory Committee, the top sort of policy-making advisory board to WHO, and indeed very early on, a very intense process of regional and country consultation process was established. In other words, we were not going to the countries and the regions and to the other stakeholders with a closed, defined product, but really a set of early ideas that were discussed, amended, and enriched by that process of intense consultation between March and June this year. An open online consultation process was also launched, and some feedback was also reviewed by that, was also incorporated or certainly discussed, and a set of different draft documents were produced until the Malaria Policy Advisory Committee reviewed a close to final draft in September 2014. So, in a relatively short period of time, we have been able to make significant progress, and very importantly, this has been a shared, a consultative, open process that has engaged more than 1,000 people around the globe. What is left now? First of all, this document will be reviewed by the Executive Board of WHO in January this year, and there will still be room for some amendments until it is finally submitted to World Health Assembly in March and hopefully approved by World Health Assembly in May next year. So it may sound heavy on the process, but I'd like to insist on the importance we attach to this. Therefore, what we will be sharing now is still somehow work in progress, much more developed and advanced than what you saw last year, close to being final, but there is still room for changes as it goes through the review and eventually approval process in WHO. We did establish a set of strategy principles, guiding principles that hopefully inspire the document and the strategy. First one, that all countries can accelerate their efforts towards elimination. And I'd already like to highlight a word that will be coming throughout the document. That's the word accelerate. And those are decisions that countries, communities, regions can take on the grounds of a number of factors, certainly the economic ones, but biological ones, health systems wise, and so on. Therefore, the capacity to accelerate, no matter where you are in the range of transmission, intensities, burden of disease scenarios that you can find yourself. So, first principle, acceleration. Second principle, country ownership and leadership. I know this is often paid lip service, but we would like to emphasize how truly this is important. The third one, and again a recurrent subject throughout the document, is how improved surveillance, monitoring and evaluation, allowing for stratification and adapting the response will be critical as we move forward. In other words, we are not proposing a one-size-fits-all approach, but rather a smart, intelligence, data-driven approach to malaria control based on local circumstances and the epidemiology of malaria in a given area. The fourth guiding principle is equity in access to services and paying special attention to the most vulnerable sectors of our community and the hard-to-reach populations, those that don't feature often in our broader statistics. The fifth one, and one in which we do attach particular importance for a WHO global strategy, is the need for innovation, both in tools and in service delivery and implementations approaches. And innovation, research and development must underpin our entire strategy for malaria control moving forward. These are the vision, the goals, the milestones and the targets as they stand today. These are global milestones and targets, and the document is pretty clear about the need for these goals and targets to be adapted by country, adapted to their special circumstances by countries. They're not prescriptive. This is a broader global ones at country level. Each country, each community, each region will define their own targets and mission. However, we're clear about this. The vision is a world free of malaria. The goals are four: to reduce malaria mortality rates globally compared with the 2015 baseline, to reduce malaria case incidence globally compared to the 2015 baseline data, countries which will have eliminated interrupted transmission, when compared new ones as of moving forward from 2015. And the fourth one, the prevention of the reestablishment of malaria in countries that have achieved a malaria-free status. Our targets by 2030 are that the world can achieve a reduction of at least 90% in the reduction of malaria mortality rates, a reduction in disease incidence of at least 90%, that at least 35 new countries will have achieved malaria elimination, and throughout this process that we will have effectively prevented the re-establishment of malaria transmission in malaria-free status countries. This may seem to be, or may seem to many of you, as aspirational goals, and indeed in the process of defining what those targets could be, we have explicitly avoided becoming aspirational, and they are actually rooted on what we believe, sound methodology that later on Dr. Cybulskis will share with you. So let me be clear about this. These are not aspirational goals, like perhaps previous exercises in some cases may have come up with. They are targets that we believe can be achieved. And we have actually worked milestones, 5-year milestones moving into 2020 and 2025, which are here for you to see. The pathway to malaria elimination, a few concepts around this. The progression towards a malaria-free status is a continuous one. In other words, we are trying to reflect and avoid on the classical definition of silos or slots or boxes in which countries find themselves, and you are in a control mode, irrespective whether you have 60% or 70% prevalence of parasitemia or you've only got 10%, and that's a different box from your pre-elimination. We believe this is a continuum, and that boxing countries and regions and communities doesn't really help. And the progression is a continuous one. At all levels of endemicity, there is in-country variation, small area variation in malaria risk, and therefore stratifying your malaria burden and adapting your program to that stratification exercise is key to optimize local responses. All countries with moderate to high transmission must ensure maximal reduction of morbidity and mortality through the current core malaria interventions as recommended by WHO, and that's quality assured vector control, diagnosis and treatment with support from an efficient surveillance system. In other words, we want to make it very clear that our first task today is saving lives today in the most affected countries. And this is not in contradiction with the aim of accelerating towards elimination. These are not contradictory goals that the malaria community faces. When programs reduce transmission, they should assess technical, operational and financial feasibility to finalize the job and indeed achieve malaria eliminations. And finally, as programs approach elimination or work to prevent the re-establishment of transmission, all cases need to be detected and managed by a general health services and reported to a national malaria registry as part of the process of certification. The proposed strategic framework is built on 3 pillars, supported by 2 elements. The first pillar really speaks about the need to ensure universal access to malaria prevention, diagnosis and treatment, the core malaria interventions that I was alluding to. The second pillar speaks on the ability, the capacity for countries and regions and communities to decide how they want to accelerate towards elimination and the attainment of a malaria-free status. And the third pillar raises malaria surveillance to the concept of a core intervention for malaria control and elimination. The two supporting elements are harnessing innovation and expanding our research base to underpin our effort, and the strengthening of an enabling environment which has multiple dimensions that we will comment on in just a minute. Pillar one, as I said, really talks about scaling up our core malaria interventions from the prevention strategies based on vector control, and in certain areas, where appropriate and adequately recommended, the different forms of chemoprevention that are currently recommended. And the second key component, the universal diagnosis and prompt effective treatment of malaria in public and private health facilities and at community level. Vector control, of course, this speaks to maximizing the impact of vector control, maintain adequate entomological surveillance and monitoring, something that is often lacking, to manage insecticide resistance and residual transmission. I don't think we can overemphasize how critical insecticide resistance is, the threat that it imposes on the gains achieved over the last decade, and how we do need to pay very close attention to this problem. Finally, strengthen capacity for evidence-driven vector control in endemic areas. From the drugs side of things, expand preventive therapies to prevent infection in most vulnerable groups, and of course this speaks to SMC, to IPTP, and where applicable also to IPTI, and protect, of course, all non-immune travelers and migrants. Diagnostic testing and treatment, you will remember our T3 strategy: ensure universal diagnostic testing of all suspected malaria cases, provide quality assured treatment to all patients, scale up community-based diagnostic testing and treatment, monitor safety and efficacy of anti-malarial drugs and manage anti-malarial drug resistance, contain, where appropriate, anti-malarial drug resistance, and ideally, in certain circumstances, and there's been a recommendation by the Malaria Policy Advisory Committee to WHO that the best, probably the only way at this point to contain artemisinin resistance in the greater Mekong region is to go for a full elimination effort in the region. And finally, remove all inappropriate antimalarial medicines from the markets. The second pillar, accelerating efforts towards elimination and the malaria-free status. And this talks to maximizing the impact of existing tools. The aim being also to reduce the level of transmission by targeting both the parasite and the vector. So here we're talking of how do we detect all infections, implement transmission blocking chemotherapy where appropriate, use the medicines to reduce the parasite pool, and this is a challenge that we have over the coming months in setting up policy-making process to make clear recommendations to countries on how to address the issue of the infectious reservoir, the large number of individuals that are asymptomatic, clinically asymptomatic, but carry parasites and allow transmission, implement targeted malaria vector control, prevent reestablishment of local malaria transmission, specific PVIVAX strategies that are incorporated into this new global technical strategy. The third pillar is surveillance throughout the spectrum of transmission, and it's about generating information that can feed into countries' strategic planning, monitor the success of those strategic planning, link responses to data that are being generated. Supporting elements, we should be optimistic because we have, I think, a particularly attractive set of innovations in tools and strategies that may be amenable to use in the not too distant future. On the vector control side, not just the new tools that are under development to address both insecticide resistance and behavioral resistance, as well as strategies to explore improved delivery mechanisms and reduce cost. Diagnostics, the promise of a specific and a lot more sensitive test for falciparum, but also the need for new tests for vivax, ideally for hypnozoites, and very importantly in the near term, rapid diagnostic test, point of care diagnostic test for G6PD status. In treatment, I think there is a robust pipeline of new antimalarials, with the hope that in perhaps the not too distant future we may have a single dose radical cure treatment available to us, which could indeed become a major game changer in the fight against malaria. Malaria vaccines, a first generation of malaria vaccine is in the process of undergoing review as we speak, and a policy decision is expected by WHO over the next 12 months. But importantly, other vaccines are under development, second generation vaccines, some of them particularly focusing on the transmission blocking capacity, are also in the pipeline, and they may become a reality, hopefully in the not too distant future. Advances in technology and communications offer prospect to improve timeliness of reporting, increased data sharing, and enhanced data analysis as part of our surveillance innovation. And in the elimination space, appropriate transmission, improved mechanisms, tools to define transmission settings, optimum combination of approaches, intervals between treatments, and methods for monitoring. Close to final, what do we mean when we talk about strengthening the enabling environment? It does speak to both international and domestic financing, which we believe will be critical over the next decade. Ensuring a robust health sector response, capacity building, ensuring an entire new generation, cohort, cadre of malariologists, ensure the sustainability of malaria responses, improve government stewardship and cross-border collaboration of malaria programs in regional efforts. As Eric has alluded to, and I'm sure David will touch upon this again, strengthen the multi-sectorial collaboration, the private sector participation, and finally empower communities and engage with non-governmental organizations. There's a whole list of outcome indicators and impact indicators proposed in the document, critical for measuring progress and accountability in the progress for this global technical strategy. WHO will try to play the role it needs to play, setting, communicating and disseminating normative guidance, policy advice and implementation guidance, and hopefully going a step forward in assisting countries and communities in implementing those guidelines. So, that being said, I'm well over time, not a very good chair for this session myself, and I will stop here, hoping that this has given you a glimpse of where this document, this strategy is going. Many of you have been part of this process, either in regional consultations or on the online consultation, and what we're looking forward is having this high-level strategy approved by World Health Assembly next year that can be translated into action by countries and regions. Thank you very much, and I'll pass the floor on to David Branting-Bennett.